started. So again, welcome everyone to Let's Talk a BIOLA's webinar series. We're excited to welcome Megan Van Noy as our speaker. This evening is called What's Your Tongue Got to Do with It? To Myofunctional Therapy. This is our final webinar in our series focused on oral ties leading into our Tequila and Tongue Ties conference on April 19th and 20th in Miami, Florida. First two webinars in this series, Dr. Ben Curtis discussed indications and techniques for frenectomies in infants, childhood, and adolescence. If you missed these two webinars, no worries at all. You can view them in the BIOLA's webinars on-demand library at educationbiolas.com. As mentioned, these webinars are a lead-in to our annual conference, Tequila and Tongue Ties. The next Tequila and Tongue Ties is quickly approaching on April 19th and 20th near Miami. This two-day conference offers a comprehensive approach to tongue tie treatment, including lectures on minimally invasive treatment using the Waterlase all-tissue laser and social media workshops. We'll end with a multi-hour session on myofunctional therapy, conducted by our speaker this evening, Megan Van Noy. For more information about this conference, visit tequilaandtongueties.com. Also find a link to it on biolase.com. We are hosting tonight's webinar on Zoom. Welcome your questions during the lecture in the Q&A feature in the lower toolbar of your screen. We will wrap up tonight's session with just a few minutes to address audience questions with Megan, so feel free to post your questions during the lecture. And then at the conclusion of the lecture and Q&A, I'll provide information about BIOLA's education CE process, additional web resources you can access to continue your learning journey for dentistry, including upcoming courses you may want to consider. The webinar is being recorded and will be posted our library in the coming days. And again, our education website that I would love for you to reference is education.biolase.com. So with that, let me formally introduce our speaker. Megan Van Noy was the first registered dental hygienist specializing in orofacial myofunctional therapy in Portland, Oregon. He founded Northwest Myofunctional Therapy in 2016 and has been working with patients locally as well as across the globe via telehealth. Collaborates with specialists in all areas of airway health, including ENTs, sleep apnea specialists, dentists, and orthodontists to address all functional underlying causes of sleep apnea, mouth breathing, clenching and grinding, orthodontic relapse, and tongue tie restrictions. Megan hosts an educational podcast called The Munch Bunch Podcast that features many thought leaders and researchers in the field, tours other myofunctional therapists in the field, and has a program to help implement myofunctional therapy and airway protocols into dental offices. So, Megan, thank you so much for joining us this evening. I will hand it over to you.
Awesome. Thank you so much, Joe. And I have a toddler, so, I'm just like a little bit busy doing all the things. So thank you so much for taking your time with me this evening to talk and learn more about myofunctional therapy. So tonight's really an intro to lead us into the big topics when we are all hanging out in Coral Gables down in Miami. Very excited. I was able to be part of the conference last year, and it was honestly, I've been in the dental field since 2012. Probably the most fun conference. No, not probably. Definitely the most fun conference I've ever been to. And so I'm so honored and so excited to be back as a speaker to talk about my bread and butter, which is myofunctional therapy. So tonight's really just an introduction into what myofunctional therapy is. And then when we're there, we're going to do a deep dive into how it actually works. What do we actually do? How do we use the research? And how to actually implement it into the dental practice collaboratively. So I'm really excited to give you guys this little taste before we get down in the sunshine together. I'm in Portland, so we had 3 days of spring and it's raining again, so I'm really excited for for Miami. So, like Joe said, a little bit about me. I started myofunctional therapy in Portland back in 2016. I graduated from Mount Hood Dental Hygiene School back in 2012. Here's all my props. I host a podcast. I've been a member in a lot of the myofunctional therapy world, and I have actually educate and mentor now. My practice has 6 associates, and we see patients in the Portland area, but globally as well, which is really, really cool. So what is myofunctional therapy? I mean, in the chat, I would love to know from you guys, how many of you guys have really heard of myofunctional therapy before? Oh, also, real quick, a little chat etiquette here. Change your chat so it says to everybody, to everyone, and not just hosts and panelists. Not that I won't love your comments, but just so everybody else can see them too. But yeah, I'd love to know how many of you guys have heard of myofunctional therapy before. How many of you guys are actually using it? I would love to know. It's a lot more people than in 2016. Let me tell you what. People, like, less people look at me like I have 3 heads now than they used to. So good. Lots of people have heard of it. We've got some no's in here. So I'm happy to see a lot more yeses than I used to. That is for sure. Myofunctional therapy. Some people call it orofacial myology. Some people call it orofacial myofunctional therapy. I call it myofunctional therapy. And our job is really to restore normal function. At its core, right? Myo means muscle, function means function, and therapy usually means some type of rehabilitation. So our goal is to restore the normal functioning. I always say it's called getting the muscles of the head, neck, face, and tongue working for us versus working against us. So myofunctional therapy can really address these underlying issues that are causing these bigger picture issues that our patients or even ourselves or our families are experiencing. A lot of people in the field got into it. I don't have quite the same story, but a lot of people got into the field because they noticed things within themselves or within their children, dug down a rabbit hole and found myofunctional therapy. My story is a little more, I was getting a little burnt out. I wanted to be able to specialize and help my patients in other ways. Found myofunctional therapy on Craigslist. It's the best. Because again, it was like 2014 when I found myofunctional therapy. And I specialized. I used my dad as a guinea pig. I got him to stop snoring. I realized I had a tongue tie, addressed that. When I gave birth 3 years ago, my daughter had lip, tongue, and cheek ties. She was the full gambit. And we were able to address all of these issues. So I've been able to really help patients on every aspect in the spectrum of tongue ties and myofunctional therapy. Usually what we're looking for as we go through, there's a ton of symptoms out there. And it really can boil down to, I'm even going to put 4 main things up here, kind of what I call the 4 T's. Tongue thrust, tongue tie, low tongue posture, and then for a certain population, especially the pediatric, I would say thumb sucking can go in here. Thumb sucking, not as much for adults. The oldest thumb sucker I have had is a 16-year-old though, so we're kind of getting up there. But usually these dysfunctional issues can come down to one of these root causes. And our job is to figure out which ones they are and then work our way backwards within the treatment planning process. So whether it's a tongue thrust, right, a dysfunctional swallow based on low tongue posture, that reverse tongue swallow, some people call it. We talk about this a lot in the orthodontic world, right? Tongue ties, obviously that's what we're definitely talking a ton about right now and in Miami. So, right, everybody's born with that freedom underneath their tongue. We all know that, okay? But on some people, it is too close to the tip of the tongue and they can't move their tongue well at all. Some people, it's short in the back. So we'll call it an anterior tongue tie. Formerly, we called it a posterior tongue tie. Some of those verbiage is changing. So some people are now calling it anterior tongue restriction and mid-tongue restriction or posterior tongue restriction. It all really just means you do not have full range of motion of the full tongue muscle, okay? We have low tongue posture, right? Sometimes we become mouth breathers because we have sinus issues. Maybe that's just a habit that we've always had. Kids learn from the people around them and their little mirrors. If you guys have toddlers, you know what I'm talking about, or if you and that can then, mouth breathing can lead to noisy breathing, can lead to snoring, can lead to sleep apnea. And again, we can go down that gambit to get to sleep breathing disorders. It can also create changes in malocclusion. If we're tongue-tied, that's also going to pull the tongue to the bottom of the mouth and can also contribute to that mouth breathing. The thumb goes in, tongue goes down, and we're constantly compensating around that thumb. So those are usually the 4 main contributors to myofunctional disorders, okay? And what we really want to see is your tongue should be fully up within the roof of the mouth. So not just the tip of the tongue, but the entire thing should be sealed, right? In that maxilla, creating a seal with the soft palate to help you breathe through your nose more easily and helps eliminate mouth breathing or snoring off of the teeth. So we're not pushing against the teeth and creating any sort of movement in the teeth themselves. Also, it can help by having the tongue fully up in the roof of the mouth, create support with that TMJ joint. One of the kind of the cheesy things I say, I don't know who else says it, but is your tongue should really be like the abs of your mouth, okay? It should be the core, really holding everything up. It's made up of, do you guys remember from anatomy how many muscles make up the tongue? It's a lot, right? And if it's down low, it's not doing its job, it's not holding your core, your head core in place, then we're going to see a lot of compensations and we're going to see things really move and we're going to see pain and we're going to see this dysfunction really start to show itself. And if we're tongue tied and we physically can't get that tongue up to seal with the roof of the mouth, then of course we're going to start seeing compensations in our body respond accordingly to help us survive and to help us function. When it comes to myofunctional therapy, we have 4 main goals. It can really be broken down to these 4 things. We want everybody to be breathing through their nose 95 to 100% of the time. Lips sealed together without tension. Tongue fully up in the roof of the mouth, not just the tip, the whole thing. And then correct chewing and swallowing. So eating, drinking, talking, saliva management, swallowing appropriately. Some of the literature out there says we swallow 3,000 plus times a day. If you're doing anything 3,000 plus times a day, that's incorrect. We're going to see the effects of that really show themselves in the body and in our habits. One of the biggest things that gets brought up a lot is this concept of, oh, it's fine, they'll grow out of it. How many of you have said that? How many of you have been told that? How many of you have been gaslit about that, right? Just because it's common, it doesn't mean that it's normal, right? A colicky baby is not normal. A bedwetting kid past the potty training years is not normal. Mouth breathing is not normal. And what we actually start to see is we don't actually outgrow symptoms, we just grow into new symptoms. So that colicky baby, that baby who spits up all the time, that baby who can't latch is going to turn into a kiddo who has a hard time sleeping, who maybe has nightmares, who maybe sleepwalks and sleep talks, who's bedwetting, right? And then they grow out of that, but then they're a teen or a preteen who has a really narrow palate and they need expansion. Maybe they're having a hard time focusing at school. And then all of a sudden they turn into this adult who's clenching and grinding, and it's not just stress, right? Clenching and grinding. They're starting to have issues with cavities. Or even kids having issues with cavities. Maybe they're having issues with gum recession. They're developing anxiety. They're having sleep apnea related issues, right? And we see this domino effect continue on. So we have to start questioning what's actually normal and what's actually common and really take a closer look at it. The idea here is getting to the root cause of the dysfunction. Why are we mouth breathing? Why are our lips apart? Why do we have low tongue posture? Why are we tongue thrusting? And get to the whys and address these dysfunctions before we get into any of these structural things like braces, CPAPs, sometimes expanders, orthotics, any other things, because if we're not addressing the function around the structures, then we're just fighting against ourselves. And that's why we see orthodontic relapse. That's why we see people not be able to tolerate their CPAPs. That's why we hear that, maybe somebody had, a kiddo can't stop sucking their thumb, right? we are seeing that we didn't address the root cause, or we didn't address the functional things that are moving these structural things around. So we end up in this loop and we get really frustrated because we're not seeing those changes. One of the biggest things that I heard when I first started out, nobody's ever heard of this before. And even still in the patient population today, why didn't anybody tell me about this? How many of you guys learned about this in dental school? How many of you guys learned about tongue ties? How many of you guys learned about myofunctional therapy, dental school, dental hygiene school? No one? Yeah, me neither. And here we are several years later, and it's barely becoming a topic. I spoke at a college for the first time, and I was like really proud of them for for asking about it. And we do know, right? If we've like looked at malocclusion, we learned about malocclusion, we know there's been rumblings, right? Since like the 1900s, right? Edward Engel, the treatment of malocclusion of teeth, stated that malocclusion is heavily influenced by mouth breathing and the muscular pressure of the tongue, right? Your tongue and your breathing forms your face. Really, this is like my favorite, really demonstrated in these photos by George Catlin in like 1870 from the really, direct book, Shut Your Mouth and Save Your Life, right? That's a book that you might want to pick up. And again, talking about nasal breathing versus mouth breathing, how it can change your face. And it's not just about changing your face, right? Like, yes, of course, everybody wants to be like good looking, attractive, right? Those conversations are out there. But by breathing through the mouth and having the jaw drop down instead of back, we're losing airway space and we're making it harder for ourselves to breathe. And that's really the core root of this. Breathing better, we feel better, we function better. And we can see all of that really come into effect through myofunctional therapy. We also had Alfred Rogers, who had written, he was an orthodontist, right, who had written and recommended an alteration of orofacial muscles with exercises, so myofunctional therapy exercises, to develop tone and proper muscle function. He felt that muscle function influences proper occlusion, and that this imbalance of facial muscles resulted in malocclusion. So we can see even back as far as 1918 that this was part of the conversation. There's biblical references. There's some mid-age references of where like midwives used to keep a long pinky nail, and after babies were born, would release tongue ties as they saw them. And which, I'm glad that we've moved past that point. Glad we have, biolays and water lasers now. We don't have to keep long pinky nails anymore. And, so this is not new, okay? I do think that the development of the internet has helped spread the word a lot more, which is great. Social media is all of that good stuff. Has been really, really great for this field to spread and share knowledge. A little more research, just so you guys know that this is research-based, research-backed. I am going to dive deeper into research and like screening tools in our presentation down in Coral Gables and when we get there. So there's just a little bit of some of the big things that have helped the field move forward. And it is research-based. Don't let anybody tell you differently, okay? I will say in the last 12 years, things have really changed as far as research. 2012, only 125 articles written. In 2022, over 1,000. So there has been a huge surge. The research is really starting to prove and come to head. And as we know, like the rest of the world has to catch up with research. So I really, applaud BioLays and WaterLays for being up and ahead with the research and really seeing, and a lot of you in here for really seeing the value and, taking the research and running with it and treating your patients at the highest level of care. Now, this was a big one for my world. This came out in 2016. It's a meta-analysis. And if anybody wants like full-on links, these are all just kind of screenshots because I wasn't going to make you read all this tiny text. You can always let me know. I'm happy to share the full articles with you as well if you're a research person. So this was myofunctional therapy alone. Okay, this was just like a big shift in the field to where this showed that Myofunctional therapy decreases the AHI approximately 50% in adults, 62% in children, and that myofunctional therapy can serve as an adjunct to other obstructive sleep apnea treatments. So again, there's no silver bullet out here. All right, everybody has to work as a collaborative team. When we're tongue-tied, we can't just get the tongue tie released. When we're tongue-tied, we can't just have myofunctional therapy with no tongue tie release. Like everything has to work together. But what we're seeing is there's a lot of collaborative treatment to be had to really help our patients improve their quality of life. In 2019, we got a little bit better definition of the different types of tongue ties, okay? Mucosal, fascial, genioglossus, and knowing kind of what involvements are occurring. So then as we can help to really identify the different types of tongue ties and what structures are all involved within that freedom tie, okay? And then of course in 2019, this was a big bad boy. All right, 2019 Laryngoscope magazine. This is Dr. Surusagi's work, and they did a study about tongue tie release, myofunctional therapy, and if it was safe and effective. And what they found out of 348 cases, there was a 91% satisfaction. There was reported 78% improvement in mouth breathing, 77% in muscle tension, 73% in snoring, 91% in clenching. And so the conclusion was that tongue tie release plus myofunctional therapy can be safe and effective together. I've had a couple thousand patients that I can also attest to on that. But now we have the research to also back that up. Again, here's all the numbers, and we're not going to spend a ton of time here because this is not a research lecture. It will be a bigger part. But right now, just to kind of see just the positive outcomes here. This is really what I want to show you guys. What you could be doing for your patients is really bringing a lot of positive outcomes between the myofunctional therapy and the tongue tie release, which is really cool. So again, happy to share the nitty gritties. Okay, we've got some tongue tie release itself. And then of course, some of the things, right, really low percentages as far as risks or complications. Some people definitely said they had some pain during it, which I had my tongue tie release when I was 17 weeks pregnant. Can attest to that. You know, it wasn't like the best thing I've ever done, but it was really, really helpful for my symptoms. Okay. It also helped us create, right, this anterior range of motion, this posterior range of motion, grading scales to get a little more familiar with that. Again, we're going to talk more through the grading scales and the different types of grading scales. We have some that are for babies, the Corliss and the Larry-Kotlos, right? We've got some of those. And then we also now have a working definition for the tip of the tongue and then the posterior portion of the tongue as well. Give us an idea of really identifying more so what this means for tongue ties and what this means for myofunctional therapy and the need for release, okay? And then there's a lot of conversations, around, you know, wound healing. Do we do with the laser, right? Do we do sutures? Do we leave it open? We're finding less scar tissue when we are able, after using the laser, to use sutures as well. Some of that is age dependent, okay? Like nobody's suturing a newborn. We'd never ask that. But just to look at some of, again, the new protocols that have been coming out the last couple of years. And then on the myofunctional therapy side of things, right, we are also looking at the structures. We're looking at what are the things that really can impact our patients and impact our patients' ability to breathe and to breathe well. So as we're going through and we're identifying patients, as we're going through and we're screening patients and the things that we're looking for, we are not just looking at the tongue, we're looking at the full big picture. We're looking at the patient as a person and not just a mouth. And we look at their tonsils to see if there's any issues or concerns around their tonsils. We're looking at the size of their maxilla, their upper palate. You know, if we're telling people that their tongue should fit in the roof of the mouth and their tongue's overflowing onto their teeth like this versus perfectly fitting inside, right? That's when we look at bringing in the orthodontist to our collaborative team, okay? So again, there's not one thing that solves all the problems, that we all work together collaboratively on that. We also look at their Mallampati score. Does their tongue block their airway? Is it open? Again, these are all just indicators for what we need to take into account as we're creating treatment plans and as we're screening. So as we move into patient care and as we're moving into these things, there is so much for us to there's so much for us to take into account, because again, myofunctional therapy is based on a series of exercises, functional exercises that target the oral facial muscles, the tongue muscles, and help us to restore that nasal breathing, lips together, tongue up, correct chewing and swallowing. In order to really understand that, we also have to look at whether or not the patient has any compensation. So we have to look at whether or not they're tongue-tied, and that's going to move into this. We need to look to see if they have any habits and, you know, what these muscle dysfunctions are in order to then create a treatment plan. There's hundreds of exercises out there. I will tell you guys that right now. And depending on like where you studied, when you studied, who you studied with, they don't even all have the same names, to be honest with you guys. And so what we need to be able to do is actually we need to be able to create a treatment plan that is the most effective for each patient, right? A lot of the bones are the same, right? Because we're working towards the same goals, but what the patient's already doing really well, where do we need to come in and provide support? Who else do we need to bring in as a specialist to this, right? And I will say it is pretty specialty based, okay? You know, a lot of times what can happen, so I'll give you guys a little bit of my story, right? So, you know, my daughter Isabel was born 3 years ago, lip, tongue, cheek tied, and she had a heart shape. She was to the tip. There was no, I knew in the hospital, honestly, I knew when I was pregnant with her hiccups. Like I knew before she came out. And she came out, absolutely, I saw it pretty much immediately because once you see it, you can't unsee it. It's a true curse and blessing. And, you know, and I brought that up in the hospital. I said, hey, this is my concern. You know, they blew me off. They gaslit me. You know, I heard one of like the lactation or the nurse leaving when like the pediatrician was supposed to come in and check and was basically like in like a tone of like, she thinks her daughter has a tongue tie, right? Literally the lip tie was creating a notch in her maxilla, and like she got all ready and she got her tongue tie or her lip and tongue done at like 9 days old. Would have been day 5. It snowed. It was February in Portland, but I digress. And so what we tend to see, especially, is that pediatricians aren't taught this in school either. Okay. And a lot of times what we can see happen and what we all check our biases about is just because we didn't learn about it doesn't make it not true. And who's a specialist that we can connect with who maybe knows more? Pediatricians are great in a lot of ways, but this isn't their specialty, right? Just like not every general dentist specializes in doing like a molar root canal. We refer to a specialist, right? Not every general dentist wants to work with kids and peds, and some people are just like so good with kids and peds, right? But they're like, please don't send me an adult. Like, we don't want to see them, right? So it's really important as we're talking to patients, really acknowledging like, hey, not everybody knows about this. Not everybody has specialized in this. Not everybody has kept up with the research. And it's really important to talk to the people who know about this stuff, right? Who have taken the courses, who are educated, who've done the learning, and really rely on them, right? You know, we go to specialists for all these other things, right? Like I wouldn't necessarily go to a foot doctor if I was having a heart attack, right? Who is the specialist? Who would you refer to? And to not dismiss people. You know, and again, with my daughter, luckily I didn't need a referral. And even when I went to our pediatrician once I got out of the hospital, she still basically told me she didn't think so. And even knowing what I do for a living and have for, 8 years, people, still questioned, tried to gaslight, made me feel like this wasn't a thing. And luckily I knew from my experience, I was able to move past that, but not a lot of moms necessarily get to wear the same hat as me and know that. But it's really important to listen to our patients, to look at these red flags and really be able to say, hey, maybe this isn't something I know about, but I'm gonna find somebody who does. I'm gonna refer to somebody who does. I want to learn along with you. And it's the world's slowly catching up, but I've always kind of made the joke, like with ENTs, their ear, nose, and throat, right? There's no extra T for tongue. We've got a couple great ones out there who are doing the research, who are pushing things forward, right? Same things with dentists and dental hygiene. The only thing that we're taught to look at on the tongue is for oral cancer, right? Is to wrap up your 2x2, move the tongue around, make sure there's no lumps and bumps, right? Whose job is it to look at the tongue, right? Everybody's been kind of like this, right? So it is our job, once we know about it, to really start to, even in speech, they're not meant to look underneath the tongue, but they're looking at articulation. Even speech therapists have to then specialize in fine myofunctional therapy and look at the full function and range of motion for the tongue. So as we learn about these things, it's really important for us to ask questions, be really open, and if we don't always know the answer, instead of pretending like it doesn't exist, be able to collaborate and communicate, do a little research on our own, and help our patients find the answers. Our job is to advocate, right? And then my job as a myofunctional therapist is to then figure out these things and make a treatment plan that really works best for that particular patient, okay? So here's all the things that we look at. Here's all of the things that we will look at as we are assessing and as we are really moving through this. These are the things that I spend an hour to 75 minutes with my patients talking about, because I really want to get an understanding of their function, of their health history, of their habits, of their sleep, right? So birth and childhood, we're finding out if they've had a vaginal delivery or a C-section, if they were bottle or breastfed, if they had a lot of ear infections or not, if they had tubes, or if they had tubes put in, if they had troubles latching, if they had troubles breastfeeding, if they would gag or spit their food up, if they had a hard time transitioning over to solids. We take a look at their habits. Were they an extended pacifier user? Are they a thumb sucker? Are they a shirt chewer? Are they a hair twirler? Are they a nail biter? Are they a fist rester? Right? Are they a desk, knee under the desk? You guys can't see my knee, right? But do they tend to be a little bit anxious? Do they have a harder time emotionally regulating, right? Are they in fight or flight? Or are they able to get into rest and digest? We start talking about speech, right? So for speech, do they have a lisp? Are R's and L's hard? Do they stutter? Do they trip over their words? Have they been in speech therapy before? Were their speech delayed? Do they talk super, super, super fast, right? Are they always grasping for words? What is it? Are they not as crisp and clear? Are they mumbling because they're a teenager? Or are they mumbling because they can't enunciate, right? Then we get into breathing, nasal breathing, mouth breathing. We have asthmas, we have allergies, we have a deviated septum, we have big tonsils or adenoids. Have our tonsils and adenoids been taken out? Are we taking medications to help with our allergies, right? So we're digging. We're really detectives here, right? We're detectives in the beginning. Then we look at their tonsils. We look at the palate, right? We're looking at their Mallampati score, like I showed you guys before. Then we're diving into their dental and ortho, okay? So notice how much background I'm getting before I'm even just looking at their tongue, right? And we want to know our people. We want to know what's going on. We want to know what their main concerns are. We want to know what's keeping them up at night. We want to know what their goals are going to be. We want to know really what are the expectations, right? So we have to go through each of these areas to really get there. So dental and ortho, have they had ortho before? Did they, have headgear or premolars taken out? Did they have elastics? Have they had ortho and now they've had relapse? Were they recommended, double jaw surgery? Cavities, right? A lot of caries, mouth breathing changes the pH of your mouth, and then will create less saliva, less self-cleansing. pH of the mouth changes, more plaque can be built. Okay, get more cavities, right? Again, I see. In my last years of hygiene before I left in 2019 for my business, I worked in pedo, and I saw a lot more pedo kids with clean teeth and cavities, with parents like racking their heads and just like banging their heads against the wall. They're like, I'm brushing their teeth, what's wrong? And I'm like, your kid's tongue tied, your kid's mouth breathing. Like you're fighting a battle you can't win, right? And then also as we get older, we're looking at recession and ortho relapse, which I said. So we're taking in this big picture. Then we're going to ask about their mouth posture. When everybody thinks about mouth breathers, like most people think about kind of the Napoleon Dynamite look, right? The really open, really obvious. We don't talk a lot about kind of the subtle, the little, just this little bit of lip. Doesn't have to be much, but having that little bit open will then make it a lot easier to be an obligate mouth breather than breathing through the nose. Our body likes to go with the path of least resistance very often, and that path of least resistance a lot of times is that mouth breathing. Then we have tongue posture. Okay, one of the weirdest questions I ever got asked when I got out of dental hygiene school. Within like the first couple of months, I worked for a doctor back in 2012. He was like kind of an early on airway guy. If you are familiar at all, he did what's called a BioBlock, which is an orthodontic appliance, and he was talking about tongue posture, and he was asking me when I got to school, he's like, did you learn anything about this? I was like, I have no idea, right? And then as I was going through my days, and I was young, I was only 22, and I was getting headaches every day. I was clenching. I used to push my tongue against my lingual bar when I would be cleaning teeth, right? And I would just be exhausted at the end of the day, and I would be like, man, I'm only 22. How am I supposed to do this for forever, right? Like my body hurts. And and he had looked at me. I had told him one time, like, man, I'm just getting the worst headaches back here, and I can't seem to like shake them, and it's every day, and I'm really struggling. And he said to me, he said, like, where's your tongue at? And I said, excuse me, what? It's like, where's your tongue living in your mouth? And I had said, it pushes against my retainer. And he's like, well, did you know your tongue's supposed to live in the roof of your mouth? And I said, I don't think my tongue's ever met the roof of my mouth, let alone live there, right? And I was the colicky baby who was a bedwetter, who had a crossbite, who needed an expander, who turned into an adult who was clenching and grinding and having acid reflux every day, and who ended up with upper air resistance syndrome, positional related upper air resistance syndrome, right? Snoring, mouth breathing. My RDI was going up. I wasn't getting deep sleep, and I was tongue tied. I had a grade 3 tongue tied that could compensate to a 2, which I will teach you guys more about. But right, so where the tongue is in the mouth and why is it there? What's the cause? We start looking at digestion. I already brought up acid reflux, but LPR, acid reflux, bloating, gassiness, IBS, constipation, diarrhea, really any kind of either side of the spectrum, right? Our digestion starts in our mouth. Our digestion starts the moment we put something in our mouth. And if we're not chewing our food correctly, if we're not swallowing correctly, if we're, swallowing air, right, that can really change our motility. That can change how we digest things. And we'll see that really start to show in our digestive symptoms, okay? Then we jump into swallowing. We're checking for that tongue thrust swallowing pattern. We're asking if we're open mouth chewers. Are you drooling? Do you hold your breath when you're eating? Does water go down the wrong pipe? Are you picky? Right? Textures, do textures bother you? Do you do little chipmunk cheeks when you are taking those bites of food? We ask about, can you swallow pills? Are you a fast eater? Are you a slow eater? Are you a gagger? Right? You guys are all thinking about the gaggers, right? Because again, like that tongue can't lift or isn't elevating to protect the airway as like something else is like entering the system, and we gag to protect ourselves. Right? It's a protective reflex. Those patients who like think that you're waterboarding them when you're just like trying to rinse off their mouth and rinse off their teeth, I would check them because you're cutting off their breathing source because they're not breathing through their nose, they're breathing through your mouth. And when you put water in there, they feel like they can't breathe. And then if they're laying back, it's a million times worse, right? Or like you're wrestling their tongue to get to those linguals of like 18, 19, and 30 and 31. And you're like, why? What is this person's tongue doing? Like, what is happening, right? These are the people that I'm looking at, okay? I've been out of hygiene for 5 years. Oh my gosh, 5 years. And, some things you never forget. We're looking out there. We're talking about their head and neck, right? Headaches, migraines, clenching, grinding, TMJ, joint issues, right side, left side, popping, crepitus. We're looking at, do they have a night guard? Do they use their night guards like, chew toys, right? Are we just putting band-aids on the problem? Or are they just using them as chew toys and actually makes it worse? They have neck, shoulder pain or tension, okay? Look at their facial muscle movements. We're looking to see if they can like move their cheek muscles independently. Can they whistle? Can they create a taco tongue? Right? We can teach that. It's not hereditary. Okay. It's a lateral tongue movement exercise. We're looking to see if they have any pain when they smile, if they can lift their eyebrows up and down. Again, are your muscles all firing? Does one side work more than the other? Is there asymmetry happening? Is your neck hulking out in order to do these things? Okay. Then we talk about tongue ties. We go through a full tongue tie evaluation and we look at posture. Are they slouchy? Are their hands on their chins? Are they, right? Like, what are they doing? Right? And then, of course, we go through a very thorough sleep assessment and assessing the sleep as well. So these are kind of the different examples of mouth posture that I was talking about, right? A lot of people think about this kid here, but more often than not, it's a lot of my patients have this really subtle, right? Subtle piece. Okay. Tongue fully up in the roof of the mouth. Okay. So a little quick tip here. So top front teeth here, we've got our incisive pill. If you start by the same letter N, you can go ahead and try that N. That's where the tip of your tongue should live all the time. If it's not, message me, work accepting patients. Just kidding. So, but it's not, and again, it's not just the tip, but we want the whole thing up, but creating that initial contact gives us an idea of home base, and we work from front to back with therapy, okay? I don't expect everything to come up all at once because there's not a lot of proprioception, there's not a lot of understanding. So starting in the tip, and also if there's a tongue tie, we don't want to like rob Peter to pay Paul and like force your tongue up to then create pain elsewhere because our body compensates, right? So don't force it. Start with the tip, move your way back accordingly, okay? And then we take a closer look at the tongue tie, right? So when we're looking at a tongue tie, there's 5 main pillars, okay? I really focus on 4. You guys would be the ones who focus on the 5th, okay? And I'll tell you what that is. But appearance, how the tongue actually looks, okay? We can't ignore how it looks. Functions, how it functions and moves, the symptoms that our patients are having, the compensations. Does the floor of the mouth lift? Does the jaw move front to back or side to side? Do we do any kind of like facial grimacing to try and like make our face and our mouth move? Does the neck overly engage? Okay. The 5th is taking measurements. So you can use a ruler to take measurements with the tongue fully up. All right. And then also the tongue just or mouth open as wide as you can. You take the percentage of that, which again, I'll show you guys that more thoroughly when we are in Miami. So here's some just different examples, right? We're looking for if there's a heart shape, we're looking for if there's a dip or a groove, okay? We're looking to see if there's any sort of attachment to those lower anterior, so it kind of looks like the Eiffel Tower, so it goes past this salivary gland underneath, right? The sublingual caruncles, if it goes past that, okay? We look at how it elevates. Does it look like a heart shape or a whale tail? Come up in a V shape, right? Does it have like a square shape to it? We look how you move your tongue side to side. Does your jaw move with you? Can you even do it? Does it drag on the lower front teeth? Does your face kind of roll in order to do this? Okay. All these are based on real patient things I've seen. Okay. Does the floor of the mouth lift up out of itself? Is that sublingual gland coming above the incisive, right, incisive edge here? Okay. You can also have a test for that, which I'll teach you guys. Again, when we get in person, it's a lot easier, right? Holding that floor of the mouth down. What's the range of motion look like there? Okay. We're looking at the suction. Then we're putting a grade on it. Okay. If we're, again, I'm going to get deeper into this with you guys in Miami, but when we're below this line here, oh, that was a really terrible arrow. So sorry, everybody. We cannot function that tongue tie, and that's where you guys come in. Okay. This is kind of the gray area. Again, I'm going to dive deeper into all of that down in Miami. But, right, so this is what we're going off of. This is what we're able to do. We're also looking at, right, lips, buckles. Okay. I said my daughter was a mall. She upper buckles, upper lip, tongue. She was the full meal deal, right? These diastemas. Okay, you can even see on this, you can see we're creating that bone notch there. All right, pretty famous like drawing on the internet. Again, nasal breather versus mouth breather. And this is where the upper jaw is the floor of the nose. And so if it doesn't fold to grow potential, then we're going to start seeing that crooked nose. If that jaw's not fully grown out, it has the no chin look, yeah, but what does that really mean? Small airway. We're small airway, we have a hard time breathing. If we can't breathe, we look tired. If we're not using our muscles, we don't have good definition in the face, right? Tongue up, lips together, breathing through the nose. We grow like we're supposed to, okay? Just a couple before and afters for you guys. How are we doing on time? Good, okay, I talked fast enough like a Gilmore Girl to really get you guys here. All right, you can see kind of droopy eyes, chapped lips, droopy shoulders, kind of lights on nobody's home, right? You can see how much she's really changed and grown here. This is my buddy Liam. So Liam had a tongue tie. He had big tonsils and adenoids that we couldn't avoid taking out. Liam really struggled. He struggled in school. He struggled socially. He struggled with bedwetting. He had some RNL issues. He would sleep with his head back because he couldn't breathe. You can see how far back his jaw's tucked, right? And this lip. Like he'd get a little red card in daycare every day, and like he didn't like his baby brother because his baby brother cried and that was overstimulating. He couldn't handle the noise because he was so tired, right? And so what we actually did for Liam is we used what's called a myomunchie, and he got his tongue tie released. We worked through myofunctional therapy. He had a little maturing to do before I was ready to like send him into expansion. So we worked on everything functionally first, and you can just see different kid. He stopped wetting the bed the same night as his tongue tie, never wet it again. But you can see his head. You can see how much his face is filled out, how much his jaw has come forward, right? He went up 3 grade levels in reading. He started making friends. He liked his baby brother, and he really just started to thrive because he wasn't so tired anymore. So, and then we work on the tongue thrust and the open bites, okay, and then we help adults too. This is my patient Wendy. Wendy had panic attacks and anxiety attacks. She really struggled with insomnia, and so we worked through myofunctional therapy as well. California sun didn't change, okay. Grayish skin tone, dark eyes. There's no weight changes between these photos, maybe 5 pounds. Her anxiety attacks went away, her panic attacks went away, because again, she was able to breathe better, sleep better, and feel better following that. So this all kind of comes back to, we figure all that out and we figure out, okay, what's the root cause of these problems? If you guys remember back to the beginning, right, we talked tongue thrust, tongue tie, low tongue posture, and thumb. Taking all that health history information shows us which of these things is it. Sometimes it can be all 3 or all 4. Sometimes it can be 3 of the 4. Sometimes it could just be 1. In my experience, there's at least 2 or 3 things happening. But we figure that out, and then we create a therapy plan for there. And so how we create the therapy plan is what I'm going to show you guys when we are in Miami, when we're talking actually at the event, because we're going to bring in the measuring tools, we're going to bring in more research, and we're actually going to show you guys how to talk about it all as a team. So everybody is on the same page. So that is all the things and more to know about myofunctional therapy in, in 50-ish minutes. I did want to leave some time, right? I wanted to leave some time for your guys' questions if you had any, and really kind of give you guys an idea of where we're going to take this next when we get together next month.
Megan, that was great content, and we do have a few questions to our audience that has been with us. If you have any questions that are in your mind that you want to pose, since we have just a few minutes before we fully wrap up, just post those questions in the Q&A feature lower toolbar of your Zoom screen there. So Megan, let me just proctor a question or two here to get things started. Question that was posted were about post exercises. So what do you recommend for post-op exercises for infants?
So I will say right now that I do not work with infants. I experimented on my own child, but I don't work with infants. That's not totally in my scope. But what we generally recommend is really making sure that we're keeping the wound site open. So as we're releasing tongue ties, right, this diamond shape occurs for everybody. That is part of it. You guys will get to play with one of the coolest things I got to do when I was there last year is they let me play with the laser, because I don't actually get to do that in my real life, right? I get to see it afterwards. So on the pig jaws, not on real people, okay? But we create this diamond shape, right? And the goal is to keep that diamond shape open, right? We don't want it to close. We want it to stay tall and wide and then heal in this way. And so we have to do massages and exercises, which is what we do on older kids and adults too, to really keep that wound open. Some will even show like a 2-finger, okay? And like for my daughter, I'd wear a little glove and we would do a finger sweep with her, okay, when she was 9 days old. And there's some other stretching. So a lot of times what we'll have when it comes to babies, we have them work with lactation. And IBCLC, since they're the part of that, the dyad is really becomes a triad, right? The lactation, the mom, and the baby. And so that's really kind of their world of expertise. But the biggest thing is keeping that wound open and tall.
Thank you. So second question here. Can you recommend any programs where you can get myofunctional trained? Second part of that, once trained, can you work in all states?
Yes. So I actually teach an introductory myofunctional therapy course. So if you have questions about that, you can message me. There's several out there. There's several introductory myofunctional therapy courses that are out there that have been around a long time. I actually think we have an instructor in here, Pat Pine. I teach an introductory to myofunctional therapy course. And yes, once you are trained, so this is kind of a weird, it's a little bit of a weird thing in which that like your license enables you to become specialized and trained, but you're not allowed to practice dental hygiene and myofunctional therapy at the same time. So you are able to practice myofunctional therapy independently and can practice in other states. So yeah, that's how I've been able to practice in other states and see patients all over the world.
All right, thank you. Your last question was curiosity about you, Megan.
Oh, yes.
So what was it that saved you from your issues with bruxism, tongue tie released as an adult?
Yeah, so I actually, yes. So I had my tongue tie released when I was 30, when I was 17 weeks pregnant, because I wanted to get it released before I gave birth. Because I knew when I gave birth that was my whole world would become about her. So I did myofunctional therapy, followed by a tongue tie release, and then the continued rehab afterwards, and was able to eliminate my clenching and grinding. So kind of practiced what I preached a little bit on that one. So, and we work a lot with adults on that, because we got a lot of adults who crack molars. and need implants, and they keep cracking teeth from bruxism. And so that is a big part of, a lot of times we see bruxism is also the result of sleep breathing disorders. So it's really important to look for the tongue tie as a contributor for that.
Great. Well, thank you for addressing some of those questions. I think it's great timing as we start to wrap up our minute session here. And as we wrap up, I just wanted to remind everyone that you can find in our library, biolace.com, including this one should be posted there. Last question here was, where can we watch this again? Well, you can watch it again at this website. Give us maybe a day or two to get it posted. You'll see there's virtual education site. When you go to virtual education, then you'll see our webinars on demand. And that's where this webinar will be posted in the next day or two, and you can re-watch it and take notes and absorb the content a little bit more, along with probably 100, if not hundreds, of webinars that we've hosted through the years on that website on varying topics. So with that, let me just go through a couple details with our audience before we fully wrap up. Said it a lot this evening, but wanted just one more plug for Tequila and Tongue Ties. For more information on that conference, tequilaandtongueties.com is the website. But I also wanted to spend just 30 seconds here highlighting some of the other content at this conference. Obviously, Megan is going to absorb several hours of the conference on that Saturday, going much deeper into myofunctional therapy during that session. But the other areas of the conference are really wonderful content, starting off with Dr. Ben Curtis talking about of Waterlays, the erbium chromium YSGG laser, why that technology is so gentle and so nice at the frenectomy procedure. Dr. Cherish, our good friend, will be discussing outcomes, tips to improve outcomes. We'll be going through step-by-step the review of the frenectomy protocol, so some clinical guidance there. And then we will have social media and marketing to help you better understand how you can leverage it to market your practice. And then one last area, of a doctor by the name of Austin McMurphy from Mississippi, who integrated the Waterlays YSGG laser into his practice several years ago, and it's really transformed his practice as he has developed a comprehensive treatment program into his practice. So he's going to be talking a little bit about his story, audience, at this conference. See you there. A couple other details, and then we will fully wrap up. An infant laser frenectomy course scheduled on July 18th and 19th, instructed by our good friend, Dr. Rashida Jaju. Her practice in Reston, Virginia, that's Northern Virginia, just right outside of Washington, D.C. She's been using the laser and has built out a program in her practice over the course of the last 10 to 15 years, and is welcoming doctors in to teach them how to integrate a program into their practice. So check that out at our education.biolace.com. If you're interested in the clinical protocol guide to me, you can find that on biolace.com. Just go to the procedures area and you'll see frenectomies listed, and you can download the PDF version of the pediatric protocol guide. You can also find education content just by going to biolace.com. And you'll find Waterlays Academy there, along with some of our classroom courses. I already mentioned webinars and other content. Coming up, 1 week from today on March 28th, our final webinar in our series for the first 3 months of 2024. This webinar is going to be focused on billing, coding, and revenue tips for the modern dental practice. Miss Teresa Duncan a good friend of BIOLA's and a great consultant in the dental industry, will be conducting that webinar. So I hope you can join us next week on March 28th about billing and coding for your practice. CE process. So you must be officially registered on Zoom and, officially registered for the webinar this evening, and attendance will be recorded via Zoom. The most important part of this that I want you to understand to get your CE is that you will get an email sent to you with a small survey to complete that survey to get your CE certificate. So be on the lookout for that in your email. BIOLA's.com/webinars. That's where you can find all our webinar content. You have any questions for the BIOLA's education team, feel free to email us at education@com. And wonderful job, wonderful content. It looked like that our audience was engaged and had some great questions. We thank you for your preparation and for your delivery of the content. Thank you so much. And to our audience, have a great rest of your evening. And we hope that we'll see you in Coral Gables/Miami in April.